online discussion group. Taking part in this group forum allows you to interact during, but also between live response presentations. So go to our website, that's terrorism.spjc.edu, click on Live Response, then the message board. Click the link for Yahoo's groups. Then click this group in the upper right-hand corner of the screen. Click Sign Up Now and then fill in the blanks. Now from the main screen you can read messages, post questions or comments, and more importantly join our chat room. Again, to sign up for the live response message board, go to our website at terrorism.spjc.edu, click on Live Response, then Message Board, follow the link for Yahoo groups, then click Join this group in the upper right. Then click Sign Up and simply fill in the blanks. Sounds like a complicated process, but trust me, once you get it through once, you'll remember how to do it again. We look forward to hearing from you and for your participation in this program. Establishing policies and procedures governing response to critical incidents is crucial to a well-coordinated response plan. Live Response explores the challenges of hospital participation in community disaster response programs.
The fundamentals of a successful hospital response plan revolves around a firmly integrated disaster response community. Emergency healthcare workers may be exposed to chemical, biological, or physical hazards, and protection is critical.
To have an effective program, you have to be able to protect your hospital from intrusion of any type of hazardous material into the hospital, because if that occurs, you've essentially shut down your emergency room and are virtually no help at that point.
Traditional hospital preparedness planning has evolved. Historically, the focus was on a narrow range of potential incidents. To increase their preparedness for mass casualties, hospitals have expanded their focus to include both internal and community-level planning.
You need to move to intermediate kinds of information, such as if someone wants to know where should victims go for additional medical care and when should they go there, by what route should they go, what transport mechanism are they going to use, what hospitals are going to be utilized, or what health facilities. That's more intermediate information that needs to be known in the next several hours or maybe even days of an event.
The old concept of the fire department or the hazmat team providing that service, most of the teams have said they're not going to be able to guarantee that kind of service. So hospitals now have to have definitive plans to do that service in some other way, and most likely through their own resources.
Communities need to develop relationships between the organizations, government, and private agencies that will be involved in a mass casualty incident. Hospital participation is essential in this communication network. It is extremely important to understand the roles of each organization and to develop the trust and awareness that is necessary for the community to respond as a whole.
Hospitals traditionally have been considered the weak link in most preparatory efforts, and so I would encourage our listeners to make sure that hospitals, large emergency and trauma centers, and hospital CEOs are invested in and participating in the development of your plan, because eventually, when there's victims involved, they end up at hospitals, and so please don't forget about your hospitals and involving them.
Increasing awareness of the need to protect healthcare workers and understanding the principal considerations in emergency response planning will help reduce the risk of healthcare workers' exposure to hazardous substances. Coordination is key, and training is the link that will help save lives.
Training is probably the most important part of developing any program. If you don't train, it's the old cliche, if you don't use it, you lose it. To me, the most valuable part of being on the hazmat team are the drills, because you learn so much through the drills and can modify or change procedures as you're going through to solve the problems that you've identified.
Basically, education is paramount.
Now we're going to take a few minutes to highlight some of the most prevalent myths and misconceptions in today's hospital response community. Let's start out with myth number one. Most victims will be funneled through the triage or the transport system. The reality, up to 75% of the victims will leave the scene and seek medical care on their own. Myth number two. Hospitals are prepared to secure and control their own perimeter. Reality, Many hospitals will expect that they can rely on local law enforcement for security. And myth number 3, hospitals consider bioterrorism to be a high priority threat to their operations and have allocated financial resources in preparation. The reality is quite different. Dr. Robert Wise is here and has a few points addressing some of these funding issues and some of the other myths that we just exposed right here.
Well, hospitals are concerned about bioterrorism, but you have to remember that this is a beleaguered industry right now. Last year it was estimated that about 30% of all hospitals were actually finished in the red. There are problems like severe staffing shortages. It's very hard to get nursing, and frequently hospitals aren't even able to open up beds that they have because of the nurses shortage. There's also infrastructure problems. There's a lot of push for them to computerize their records. The electronic medical record is something that the hospital industry has been looking for the last 20 years, and it's a very expensive thing to put forth. And there's the expectation that they move more and more to a computer record. And the last is that the expectations of what a hospital needs to do just never stops. For instance, about a year and a half ago, a report came out from the Institute of Medicine describing that there are somewhere between 45,000 to 90,000 deaths that occur through errors in the hospital. Obviously, this is of great concern to the hospital, and a great deal of attention is being put to try to deal with those types of issues. These are the issues that that the hospital has to deal with now. Often, bioterrorism is seen as a problem that can be put on the back burner and it can be waited to be handled. And so it may not be the kind of priority that some folks would like it to be.
I think one of the things that we found in our conference last year with the Johns Hopkins Center for Civilian Biodefense, which you and Steve participated in, was that the hospital CEOs as well as the practitioners saw that while this was an emerging issue nationally, that it wasn't getting the attention, that it was adding on to an already beleaguered industry, that there was an element of unfunded mandate to it, and how we could possibly get hospitals to prepare for one of these in a time of need when they're having a hard enough time meeting the other requirements you mentioned is very difficult.
Kevin, I'd like to add to that also that I think there's a real problem getting the physicians trained in this area. I mean, they are not a group that are paid to train as many other providers are, and getting them interested for something that has a low possibility of occurring, but it could have devastating effects is a real problem.
Well, I think the other consensus from that group was that there were a lot of resources being dedicated to terrorism and to chemical and biological terrorism, but that the health community just wasn't being included. And not that money is all the answers, but the change, a shift in change to show that the government and senior leaders are very interested in this issue. Secretary Thompson has taken this on for HHS and is moving forward with the new priorities for hospitals this next fiscal year.
And I think also that the hospitals as a whole think that this is not going to happen. You know, they really truly believe that, so why expend these resources on something that would be a rare occasion? So it becomes an issue for them.
Well, yeah, and training, making sure that we're not just training for a rare event,
That's exactly
but
right.
from an all-hazard standpoint. We can
That's exactly
possibly
right.
reinforce those things that they're going to need to do in any circumstance.
Now, one of the things that we're going to try to do with our program today, if you're watching us right now, is to break this down into roles and responsibilities, the preparation process, then talking about standards and guidelines, and then finally kind of wrapping it up with some recommendations that you may be able to walk away from this program with that might really help. Let's go to Lisa Rotz, who joins us from the CDC in Atlanta. I guess one of the responsibilities that you first talk about when we talk about a bioterrorism event is who's the person who makes that first call?
Right. If we think of emergency departments and emergency department physicians as potential first responders in a biological event, we think of these people as the ones that are going to see the first victims that walk in to their emergency rooms. And there are certain things that they can look for that are fairly nonspecific and in general might indicate anything going on in their community, whether it be bioterrorism or some other large adverse public health event that they can look for that might alert them to something going on. And some of these things include if they see a large number of ill people walking in with similar symptoms, all occurring within a same amount of time, within hours or days of each other, this might alert them to something unusual going on. Or if they see a specific population, such as adults presenting with illness that you don't usually see in adults, such as a rash illness, that also could indicate that there's something going on in their community. It may not be very specific, but it can alert them to something early on. Other things that might indicate something is occurring would include seeing or diagnosing an illness that you don't normally see in that area, geographically or seasonally. If you don't normally see plague or tularemia in an area of a country, and all of a sudden you're seeing a case or two that you think are plague or tularemia, that might indicate that something unusual is occurring, as well as if you start to see an increase in respiratory illness in the summer when you normally see those sorts of things in the winter. Now, none of these by themselves would indicate that a bioterrorism event is occurring, but it should be enough to alert you to the fact that additional investigation should occur, and so that you should alert somebody to the fact that you think something's going on. And that would include internal notifications in your hospital by whatever protocols that you have set up, as well as external notification of public health authorities so that they can investigate to see what else is going on in the community. And you shouldn't be afraid of alerting to these sorts of things. Some people might consider, I don't want to blow the whistle too early, but alerting somebody to a potential event doesn't necessarily mean that a full response is going to occur right away, but it will allow for early investigation.
Mm-hmm. Kevin?
You know, one of the things we're trying to do in local communities with CDC and the Office of Emergency Preparedness with Metropolitan Medical Response Systems is to get beyond the barriers of the different groups and to try to link together different cultures of response, both public health, medical, public safety, as well as looking at connecting the threat assessment piece with clinical diagnosis and awareness, getting back to what Steve was talking about in terms of training. If they don't see it and they don't know it, they can't call anybody. Mm-hmm. And making sure that law enforcement from the threat assessment side is contacting the clinicians if there's a threat. An epidemiologic investigation can only start once a clinical diagnosis and awareness is starting to be made, and of course linking in the laboratories, both the clinical side as well as the laboratory side. 4 real important legs on this chair that we have to be looking at connecting.
Mm-hmm.
And I agree, going even a little further with Kevin, is to include the multidisciplinary groups, including your pre-hospital care providers. Because listening to them as they come in the emergency department, if they say they might have seen, this might be their 6th patient with the same type of symptoms that they're seeing, that also should be a trigger for you to maybe look beyond and see what's going on.
Okay, one more question before we move on to our next area. People would say, you know, we're so sophisticated with our computers and with our data processing systems, wouldn't that be the place that first notices it, that somebody's going through the system, they go, well, here's a match here, and here's a match here, and here's a match here? Or are we expecting too much of the data?
I think it really depends on the system. I think in most instances it's still going to be the human that says, you know, this is the second really sick, otherwise healthy individual that I'm admitting during this 8-hour period. Something might be wrong. Or as Leslie pointed out, it's the pre-hospital care guys that say, you know, I've taken a lot of these people to other hospitals. I still think it's going to be a human trigger. Now, we may get to the point where our data processing systems and artificial intelligence systems can help us, but I still think for most situations it's still going to be the humans that will be pulling the trigger.
It's also important is that what Stephen said, that if a rare event occurs in a single hospital, somebody's going to say, whoa, what does this mean? But if you have a city that has 6, 7, 8, 9 hospitals, there's a good chance that one event's going to occur at hospital B, C, and F, and there really is no system that allows that type of surveillance to occur that pulls that information together.
We've heard from the hospitals that the single biggest thing that they need really is somebody in the hospital to be able to be part of that linking chain to the public health group, because they simply don't have the staff to do it. And whether it's automated or by human, it's still a critical link, because if those 5 or 6 or 9 hospitals don't get that information in, it's going to be a long time before we discover it.
Let's talk about preparation and how important that is. Michael Bell joins us again from the CDC in Atlanta. Michael, how do hospitals prepare for situations like this?
Well, I think it's important to be very clear about what the facility goals are. I would suggest that the things that we're really after is to maintain the function of a hospital so that even after the initial wave of people arriving happens, you can still go on and care for them. I take it back to the beginning of the program where we pointed out that we're talking about hospital responses to a biological event. And this is inherently different from chemicals or explosions, where a lot of the action is going to be very upfront. You take care of your casualties, and then things simmer down. Whereas with an infection and possible communicable diseases, you're dealing with something that's going to need ongoing care within the hospital. So maintaining the ability to provide that care is critical. It's easy to think about care just as a clinical issue with doctors and nurses and so on, but in reality, we can't deliver that care if we don't have housekeeping support, if we don't have nutrition, if we don't have a lot of other things that make a hospital work. So that, I think, needs to be incorporated into our plans, and that has to be the major goal, to make it continue to function. And the other thing is to make sure that we can do this while protecting our personnel and protecting our patients from transmission of disease.
Go ahead.
And the other thing, and I definitely, agree with what Mike said, in addition, though, is the training becomes a major, not only problem, but a major need for the hospitals. The problem, of course, is, it's extra staff time or bringing extra staff to cover when they're going for training. It's doctors and physicians' time that they're not paid for, but to make it available in a manner that it's easy accessible for them.
One of the single biggest things that came up to support, again, one of Mike's points was AHA convened a group, and basically they said, wait a minute, we have an awful lot of single parents in the hospital community. If we can't do something to assure and ensure that their families are going to be taken care of, that they feel that they're in a safe environment and that their loved ones are in a safe environment, it's really going to compromise our ability to make sure we get people there.
Robert, let's start with you just for a second. Let's go back to, let's go in a more organized fashion here. Let's start from the beginning. Where do you start as far as this process is concerned for being prepared in advance?
Well, the first thing that one needs to do is look out and see what type of hazards are already out there. The Joint Commission asked that a hazard vulnerability analysis be done, and that most hospitals, when they look out into their environment, they're not going to see bioterrorism as one of the top things they have to worry about. But they will see other things, and those other things may be, for instance, flood. You only have to see what's going on in Houston in the last number of weeks, or all the flood that's gone in the Mississippi River. There are many communities out there that are facing lots of potential disasters, that they can begin to put a response system together that sets the groundwork for some of the larger problems that will eventually face it.
Next step then after beyond that?
Let me pass that on to somebody else here to pick that up.
Stephen?
I think that again, training is a very important issue. I think we need to look at our supply lines, especially dealing with a bio incident. You need to worry how much, in terms of antibiotics, do you have in stock? I mean, many hospitals have gone to just-in-time stocking, which means we've tried to minimize our inventory. And in fact, you may have all the hospitals in one area pulling from a common supplier. So suddenly, if there's a big mushroom in your need, you may not be able to have that need fulfilled. So we need to look at some of our stocking issues. And as I mentioned, training is still a very important issue, and ongoing training for our staff.
I think in terms of resources, it's very important not only in terms of the material resources, but also the human resources. We found in planning after planning effort in cities that many of them are counting on the same service unit nurses or contract nurses, and they're triple and quadruple counting the available human resources. And so to get a very realistic look at what human medical resources are available.
Go ahead.
I would say it's very true because, look at our influenza season. Our hospitals become overwhelmed at that point, and there isn't nursing because they're all pulling from different agencies to bring in the nursing. There aren't any more beds available. And looking at ventilators, they're all pulling together ventilators and monitors into the hospital, and the resources just aren't there for them. And we haven't been able to handle that yet.
Let's go to Michael in Atlanta very quickly. Michael, is there a way that, because I'm thinking that in a metropolitan area, such as the Tampa-St. Petersburg area, we must have 20, 30 hospitals. In measuring the capabilities, do these hospitals communicate with each other and know what each other has?
I think in some instances they do, but in reality, the communication is pretty limited. Echoing what both Steve and Kevin were saying, I think it's critical that hospitals start their preparation by figuring out what they actually have that they can get their hands on, whether it's antibiotics, like Steve was saying, or personnel. I think personnel is a critical issue. You can imagine that when something frightening happens, there are a lot of people who are going to be worried about their families, who won't show up for work or who won't be able to show up for work. If that's the case, you're going to be short-staffed, and as was pointed out, a lot of people are going to be looking at the same overflow staff to staff their various hospitals. And that's not going to work. So looking very realistically at what you truly have available for your facility, and then talking to others about what resources can be shared, I think is a very important first step in preparation. One other thing that I'd suggest is looking at how normal hospital things apply to these sorts of preparations. In other words, with regard to infection control and hospital epidemiology, you've got resources there that will be very important to defending a hospital against a biological event. And looking at that in advance makes a lot of sense.
Let me ask a question there too, because I got to thinking in this whole scheme of things, hospitals on a business side of things are in a good way notorious for protecting their own turf. Now, do you get in a situation with an inner city hospital saying, well, there are more people in the inner city that are more likely to be affected than out in the suburbs, therefore we'll take on that responsibility? Or does a suburban hospital say, we're out there, we'll take on that responsibility?
You know, I think a straightforward way of doing this is doing what Leslie did in her state. And I think your work has been remarkable, and I just want to congratulate you. It also gave us a very real reality call.
Yeah, exactly. Thanks. I appreciate that, and I was going to mention that. We did a survey in Illinois of all the hospitals, and we divided it up into 5 parts. We had administration, pharmacy, infectious disease, communications, and emergency departments. And we surveyed them on what their capabilities were, what their knowledge was, and were they able to be prepared. With a lot of coercion work, we got 100% of the hospitals in Illinois to respond.
Coercion.
You know, being public health, it's a little bit easier being a regulator. And we did really find it so interesting. I know we shared it with a lot of people, and then we mailed it back to all hospital administrations so that they would see what they're lacking and maybe get an idea of where they stand.
So that model is available for you from Illinois. All the rest of you are watching that right now, especially if you want some input. We're going to continue on with our discussion, and we're getting a lot of good questions that are coming into us, and a lot of the questions that you'll have we'll be able to answer a little bit later. Now, we'd like to remind you that you can be a part of this discussion, and we encourage you to be by calling this number. This is our toll-free number, 1-888-870-3000. Now, that's for any questions you'd like to ask our panel now, and I always tell everybody, go to your phones and get there right now, because the last half hour will burn by so quickly you'll wonder why you couldn't get your question in. If you don't like to talk on the phone, you can also fax your questions to us. That's 727-893-9816. Okay? And don't forget to visit our homepage. That's terrorism.spjc.edu to post your questions and comments on our message board. Our program will continue.
Join us for the next ComNet when we visit Orlando, Florida to take a closer look at the highlights from the International Conference on Disaster Management. We'll feature the specialized incident management skills of the National Strike Force and continue our focus on hospital response with a follow-up on incident command systems. A top-off update on Incident Unified Command during a WMD event, and the latest news in the response community. ComNet airs Wednesday, August 22nd at 2 p.m. Eastern Time. For more information on viewing ComNet, make sure to register online at terrorism.spjc.edu.
Back to our panel and back to you on the telephones. Like I say, go to those phones right now and we'll be able to get your questions in. Our program only lasts an hour. We're down to the last half hour. Let's go to Steve in Reno with his question. Steve, go ahead. Steve, are you there? Steve, one more time.
Okay, hello.
Hi, Steve.
There.
How you doing? What's your
Good.
question for us?
My concern is putting hospital executives or administrators into the same room, talking about their capabilities, and wouldn't that be an antitrust violation?
Anybody want to... we don't have any lawyers on
Well, I
staff.
was going to say, yeah, don't they do that for normal diversion?
I don't think that, I think if they sat down in the same room and started to talk about what they were going to charge for each bed, they might get in some trouble. I think the type of work that we're talking about here is how the hospitals will communicate with each other, coordinate with each other about a very specific event that is viewed as an emergency for the community, and also connecting with the community. So the issues that would be generally thought about antitrust, I don't think would be a barrier to the type of work that needs to be done
Plus,
here.
we collect that information on when hospitals go on diversion, number of ICU beds, available number of monitored beds, and staffing, so that information is ongoing available.
And there is precedent in terms of both WMD preparation and normal disaster preparation of hospitals working together in terms of their capability. And I think I agree, as long as we keep it medically oriented, there won't be a risk of antitrust problems.
We have a...
I'd like to add in, it'd be great to have a bunch of hospital CEOs sit around and discuss this, because that's one of the groups that we've had really a hard time getting in and starting looking for disaster preparedness. So,
Michael, you've got a comment from Atlanta on this question.
Kevin just beat me to the punch. I just want to suggest that having administration participation in any kind of planning right now is critical, because that's where the money starts.
Absolutely. Let's go to Dr. Bowler, who joins us by telephone from Virginia. Dr. Bowler, how you doing today?
Good. How are you?
Great. Your question, please, for our panel.
Yes, I'm an emergency physician, and I also have the concern that we're not getting exposure to adequate training because it's on our own time. Have there been organizations working with the American Hospital Association or the American Medical Association who are trying to get continuing medical education credits for training emergency physicians?
Well, we've had 3 hands go up, so we've got you covered on this one. Leslie, go ahead.
We worked with the American College of Emergency Physicians in Illinois, and we give CME for our preparedness and training program. We also then give CME for nurses and for EMTs. That way, at least they're getting some type of credit for attending, and we do a 4-hour training program in Illinois for that.
And at the national level, the American College of Emergency Physicians has incorporated many aspects of what WMD training into several of their teaching programs. So that we recognize that's an important issue.
and Dr. Wackerly just published a article in the Annals detailing 2-year effort, and I think the caller is right. The big issue was time and credit. Those are the big barriers, and we are seeking in every national effort, whether it's through the Veterans Hospitals, which is a new effort kicking off, as well as at our Noble Hospital, as well as distributing Train the Trainer, that CMEs are a really important aspect. But we first focused on what is it that they need to know, because getting the competency-based understanding of what it is they need to know rather than just going to courses is also equally
And I think
important.
there's another exciting thing here. I know several groups are working on web-based training, trying to develop web-based modules. So in fact, you can do it at home at 3 a.m. and still get credit for it and not have to worry about the expense of travel.
Dr. Rotz in Atlanta, you had a comment?
Yes, I just wanted to point out that that we are also working with professional medical societies such as the Infectious Disease Society of America to develop web-based resources for physicians to train and educate physicians on the different diseases as well as the different aspects that they need to prepare for this potential eventuality.
Let's go to another phone call. We have Jackie, who joins us from San Diego. Jackie, you there?
Yes, I am.
Go ahead, ask your question for our panel today.
Okay, well, we've been talking about hospital-to-hospital communication, but we're calling from the County Public Health Department, and our question has to do with how the hospitals envision most effectively communicating with us regarding the number of patients coming in, the symptoms. We're aware that their ERs will be inundated, but at the same time, we have the responsibility of conducting surveillance. How would that best work for hospitals?
I think there's one very important issue that comes up. Do you have 24-hour coverage? Many health departments do. Some, in fact, do not. So you call at 3 a.m. because your suspicion has been raised, and now you can't get hold of someone important. So first of all, what is your coverage there? And is this a communication pathway which has been well-traveled before? In most cases, it has not been well-traveled. I think it's important, it's incumbent for the hospitals to establish that communication path, but it's also incumbent upon the public health departments to also establish that communication path.
All right, and we're just going to remind you to keep those phone calls coming even as we move on with our discussion and start covering more of these topics. You had one more comment to make.
Just that we also, when we did the hospital survey, we did a local health department survey in Illinois, and we had 94 local health departments, all of which answered the survey. And, you know, just like Steve was saying, a big problem was that there wasn't 24-hour availability and coverage. But we've also then tried to work with tabletops, including hospitals with their respective local health departments, so at least that they're talking and working together.
I think just as we've spoken, and Lisa and Mike can speak better this than I can, but I think we're asking the hospitals to do an awful lot at a time that's difficult for them, and the same goes for public health departments at the local level.
Well, one of I guess the next natural offshoot of a topic we want to cover is standards and guidelines. Who's establishing these guidelines and the standards so that everybody, as the phrase goes, is on the same playing field? Dr. Wise?
Well, the Joint Commission recently put out a new standard called emergency management, and it went into effect in January of this year. Now, actually, the Joint Commission has had a lot of history of doing emergency preparedness, and I think the name, as we switched it from preparedness to management, gives you some sense of what has changed. That we really have broadened the expectations. Before, preparedness, I think, was just what it was. It was much narrower. We've now moved to looking at things in a broader way, all the way from mitigation, preparation, response, and recovery. The other thing is that we're looking at as an all-hazard preparedness. That before there was a greater emphasis on building a system for a specific problem, a tornado, a hurricane, or whatever. And now there is a much greater emphasis to create more of a generic structure that allows the organization to face any of the hazards or disasters. And along with that, there is the expectation that some sort of unified command structure be put in place, and also creating systems that have interoperability with the systems that exist out in the community.
If I could just commend Bob for dealing with the unified command. I think it's a very important component of any healthcare system. And in fact, I would propose that that even be extended further into the public health sector. Unfortunately, any type of bio attack is going to require very rapid decision making. And quite honestly, most public health departments are not set up to exercise rapid decision making. It's more of the consensus based, let's look at the couple papers in JAMA and see where we want to go, rather than we have 3,000 decisions to make in the next 20 minutes. How are we going to do it?
Mm. And who's overseeing to making sure that all of these agencies and the hospitals and all of these other first responders are able to respond with these standards and the guidelines that you put forward?
Well, the Joint Commission looks at most hospitals in the country about once every 3 years. Mm-hmm. And we are now, what we will do is that we talk to the organization, see how they are moving towards it. We don't expect that it all be done at this point, that this is a standard that just began in January, so that we are having conversations, we're educating, consulting with the hospitals to see where they're going and how they are progressing towards building a more sophisticated and complete system.
Best practices, any things we should be talking about along those lines?
Best practices around?
With standards and guidelines. In other words, what works and what doesn't work, so that hospitals and public health departments aren't frustrating themselves with using models that haven't worked.
Well, that's actually a good question, because a lot of what's going on in the individual communities is not well, is well communicated. And actually what the Joint Commission is talking about right now is to begin to have conversations with communities that have in fact had a disaster, to find out what's worked and what hasn't worked, what they wish they had done and what they will do in the future. And our hope is that we can create a forum in which some communication can begin to take place.
Mm-hmm. I think that right now we're a far way away from really establishing hard standards. I think best practices, guidelines, and learning as we go is where we're looking at it, and making sure that we're looking not only at training aspects, but facility modification, as well as human resources, and how people share information. And we're really trying to work both with the public and private sector, pulling in the best ideas. Things like this are a good example. Meetings that go on during the year, and our effort is to try to move this into a best practices standard, but we're still not there.
Michael, did you have a comment from Atlanta?
I'd just like to remind us not to forget that the Joint Commissions and many of our partners already have some very useful standards that apply to this. Getting one step beyond the initial response to an event, the guidelines that we use to protect our healthcare workers and prevent transmission of disease within hospitals, those are very important things. And if bioterrorism preparation can be used to promote effective training and retraining on those points, that's a very beneficial thing. The same is true for laboratory safety. There are some very good guidelines that exist already that protect our lab workers from exposure to bad things. And again, this is a way that we can support some of those safety issues. A point on training, before I forget, I think it's also important to remember that training needs to extend beyond our first line of response, being, for example, emergency department and perhaps intensive care. I think it's important to include our colleagues in other disciplines. If the pediatric service, the OBGYN service, the surgery services are baffled, scared, and have not had any information beforehand, it's going to be much harder for them to function during a crisis. The same goes for pharmacy, laboratory, food services, and so on. And I think one of the important things that hospitals need to think about is how training can be given to everybody at appropriate levels so that the hospital can continue to function.
But I just like to point out there's a real problem with that. I mean, even with emergency physicians who are that's where the rubber meets the road. We have a terrible time trying to get them to get trained, and let alone the OBGYN guy, he'll laugh in our face. So that's a real tough nut to crack, and I don't know the answer.
Well, and I think another group that we really haven't talked about a lot beyond the hospital-based folks, and I know that this is what this is focused on, are the family practitioners.
Right.
Absolutely.
Nursing
Exactly.
family
Right.
practitioners and as well as others, pediatricians, and linking them together.
You know, one of the things that also, as I'm listening to your conversation, it strikes me, you know, drills are wonderful, and we've all seen how emergency preparedness folks do the airline drills that they're required to do at airports every 3 years. But when we're talking about an event, a bioterrorism event, we could be talking about anywhere from as small as 100 to as many as 10, 20, 30,000 people being affected. What kind of preparation can you do, numbers-wise, for the hospitals?
Like, numbers-wise, it's a real issue, but I think, again, you have to look at it from a systems point of view. We can't look at it from the individual hospital point of view. You have to look at it as a metropolitan area or a systems-wide issue, because we have to have that communication going on. I think the lack of what we call surge capacity in hospitals today is a major, major issue. Without question, the system will be way overwhelmed. I think we cannot prepare absolutely for that, but I think by looking at our material and maybe some of our personnel issues and how can we guarantee that the personnel will continue to come to work, we can do at least a better job.
I think another area that we have to look at really is going to be, and we don't have answers, changing standards of care, a paradigm shift of care during the middle of one of these, and how we communicate that and how practitioners feel comfortable operating in those types of environments, because there just isn't enough there.
And not to be a pessimist, but in fact, I think a bad incident, you could end up looking like Venice during a plague attack in the Middle Ages. I mean, it could be pretty gruesome.
Even a small, you know, just like Steve's talking about that we experienced was the heat crisis in '95. Our hospitals became overwhelmed in Chicago over a long weekend where we didn't realize what was going on. And at one point on the weekend, we had 18 hospitals on bypass and diversion. They didn't even realize that they were dealing with a crisis situation, kind of correlating it to a biological event that, you know, it just becomes progressively worse till you're overwhelmed.
I think that one could start to feel discouraged.
I was just about to ask that question.
And the point is that this country is not ready for being able to deal with a bioterrorist attack. It may not be ready in 5 years, but that doesn't mean you say, oh my gosh, we're never going to be ready, therefore we won't do anything. That one begins to build the structure, do the thinking, do the planning, and you incrementally build it. You know, when Kennedy said we're going to get to the moon by, 1970, that was almost 10 years before. It takes that long to be able to produce the kinds of processes that are going to be as complicated as what needs to be done.
Now, are some parts of the country just better equipped to handle that? I'm thinking of, because this program is coming from Florida. Florida is, and anybody along the eastern seaboard, we're so used to hurricanes that it's like, okay, I've got my stuff ready to go through June through October in a hurricane shelter. But because we have run the drill often, everybody knows it, the public knows it, that if it were to escalate to a bioterrorism event, it might be easier for areas that have already experienced some kind of level of preparedness to have to deal with something like that. Is that a myth, or is that not true?
I think it's difficult to translate. And I think the difference is going to be the fear factor. And I think also people, I think the Chicago heat is a perfect example. Influenza in cities during this series, during the winter, is another good example. We're trying to pick up on models. I know that we're working hard to try, HHS is, to try to figure out what there is to bring to bear here. But we rely on volunteers from the community. And if it's in all of the communities, it's going to be very difficult to pull those volunteers out and move them somewhere.
Unpredictability. Are there studies that actually try to determine what are the unpredictables, the things that you think you can plan for that you actually can't? Or do we wait until it happens and then go back in that? Anybody?
Well, I think in many cases we really don't know. We tend to learn by disasters that occur and then we go back and critique them afterwards. But I think something on this large a scale has not occurred, and it will put stresses on the system that we've never seen before. I think we can learn from history, however, if you go back and carefully study the 1918 plague, or not the plague, but the influenza outbreak, that we learned that we had to be very creative. We had patients in libraries, as an example, in schools. Now, I think there's even a worse question for that. We couldn't really do very much. Now we can maybe treat, but how can we get the material there? So I think we have to extrapolate from past bad experiences.
And I think the federal government is taking this very seriously. The Department of Justice is looking at its next series of exercises focusing on the consequence management side and recognizing that this is a very difficult health issue, and to focus on those and not necessarily declare victory after the bad guys have been caught, but to see how this would play out.
Sure.
But this is exceptionally difficult because, as Bob has pointed out, all these hospitals are already under stress. How do you take them offline to exercise this in a meaningful way?
That's a good question.
And these are some things that we're trying to work with them on.
We have about 15 minutes left in our program, so if you have a question you'd like to ask our panel today, here is the number to call, 1-888, that's a toll-free number, 870-3000. Again, 1-888-870-3000 if you have any questions. Also a reminder that you can also ask questions when our program is over by going to our website, and we'll be able to address some of your issues there as well. If you don't want to call us but you have a fax, here is the number to call, 727-893-9816. Let's go back to Michael Bell in Atlanta, who has a comment for us. Michael?
I just wanted to reiterate Bob's point of not being too discouraged. It is a big task. There's a lot that needs to be done, but there are certain elements of preparation I think that need to be built regardless of what we're trying to address. And those are the things that we've already discussed: communication systems, effective sharing of resources, assessment of resources, and figuring out exactly what we need. Those things need to be done regardless, and I think they have benefit beyond just a single flavor of terrorism. I think they have benefit for almost any kind of disaster planning.
And I think that's one thing that we've found when we go into cities and look at mass casualty plans within the hospitals for any disaster, that it's something that you have to take a lot of attention to and continue to work, because mass casualties in any event, whether it's chemical, biological, or disaster, are going to really need to be dealt with. And those communication mechanisms across city and state different groups are going to be critical, and exercising that communication is probably the biggest thing that we can do.
And I'd just like to reassure, none of us, I think, would be here today if we didn't feel there was a lot that we could do. I mean, if it was completely, we can't do a thing, then there's no hope. But in fact, the fact that we're here and this is an educational effort, I think, speaks to the fact that we can do something.
Okay, we have about 10 minutes left in our program, so what we want to do is we want to get real specific now. What, for each of the segments that we're going to put up on our screen, can we do to help facilitate efficient, effective hospital participation? Let's go down through, right through the list, and have you guys answer this. Fire. What can fire folks do?
Well, again, you hate to keep harping on the same issue, but again, education and recognition is an important issue. In many communities, it's fire-based EMS, so you can kill two birds with one stone in terms of the education there. They need to understand the potential of what we're dealing with and some of the basics, and that goes for public safety as well in terms of police. Part of it is to educate these people so that to minimize the panic. We all fear the unknown, and even though they may not be intimately involved in the care of patients, for them to have a reasonable understanding of the problems that they may be dealing with, I think that's important.
We got a phone call right now. We'll get back to each of these segments. We have Al from Virginia who's calling us. Al, go ahead with your question for our panel.
Okay, with most of the hospitals in the nation now being for-profit hospitals, are there any mechanisms in place to recover costs after a particular event? Not only costs for services, but costs for possibly damage to the facilities or contamination in the facilities. Are there any mechanisms where these hospitals can recover the cost incurred?
Go ahead.
Kevin, you probably know all the nomenclature and everything, but my understanding is that there are federal statutes that will, in fact, compensate certain degrees of involvement in terms of disasters.
Well, not completely. And that's one thing that we're working on right now, and that is a mechanism, quite frankly, for billables for patients. In terms of facilities and any other types of damage, that would come generally under the Stafford Act if it were a declared event by Federal Emergency Management Administration. But we are working on how do we compensate care providers in a time of need when all other insurance has gone away. And we're very hopeful to have that in place within the next 3 to 4 months. In terms of the others, they really come under the Stafford Act. And that's what's difficult about a bioterrorism event. It doesn't take out facilities. So we have to start thinking in different ways.
It's just, we've also looked at ways for reimbursement, and it is real difficult. We did pass legislation, though, that if it is a declared emergency, the response people and the hospitals that use medical supplies will get reimbursed. They must keep a list, and we must have approved it, and we'll reimburse them for any medical supplies. Not for the time and effort of the people, but at least for the supplies that they use.
Okay, again, our phone lines are still open. Let's kind of get back to our summary that we've been dealing with. We talked about fire. Let's talk about police and EMS. How can they better prepare?
Well, I think even like for police, EMS, and 911, again, it's what Stephen, we've been talking about, it's the training, so that they recognize when 911 is getting calls for the same type of complaints and symptoms, that should be a trigger. They should look at response times of ambulances or transport times. Our ambulances that routinely go in one area now going further and further because no one's available. Some of this should all be a trigger, and that goes through training and recognition with them.
We need for the police and the infrastructure, fire, public servants to be there.
That's right.
Mm-hmm. Now we know that, and this is one of these statistics we've talked about on this program before, that when one of these bioterrorism events goes down, God forbid that it ever should, that as many as 20% of those kinds of people, including hospital workers, may not show up.
I think 20% is maybe whistling in the dark.
Right.
It may be
okay, well,
and I don't think we have any real basis for that,
right.
Other than conjecture, but we have to prepare for that.
Right.
And part of that is by training and increasing knowledge and taking, right, as Mike said earlier, taking the fear factor out.
Let's go to Brian, who joins us from Oklahoma with a phone call for us. Brian, go ahead. What's your question for our panel today?
Yes, the question I have deals with surge capacity. We talked about the influenza model, the heat model there, and